And now we have Planning Committee member Mary Ellen Roberts to introduce the first of this year's 3 interactive panels focusing on the shift in healthcare payment from fee-for-service to bundled payment. Mary Ellen.
Thank you, and welcome to our first panel on fee-for-service to bundled payments. Joining us on the panel today, and I ask the panel members to come to the stage, are our physician colleague, Dr. Christopher Stanley, who is from the Catholic Health Initiatives, our newest edge runner, and congratulations, Lauran Hardin from the Mercy Health System, and our moderator, Ellen Marie Whalen from Center for Medicaid and CHIP Services. Again, we want you to please remember that if you have questions, please use the cards on the tables and raise your hand, and one of the Jonas Scholars will pick them up. There will be time at the end for open mic during the last 10 minutes of the program. Now I would like to turn this over to Ellen Marie.
Great. Can everybody hear me? Let me start up here then. And oh, you can now. See, if I turn my head, it depends on how I'm turning it. Okay, well, we've got our work cut out for us because in addition to being after lunch, we also have to follow Risa's amazing talk, and we get to talk to you about payment policy. So we have to try to keep you awake and alert and engaged, and we are up for the challenge. Let me tell you a little bit about what the next hour is going to look like. And then we're going to launch right in, and we're going to hopefully make sure that we have plenty of time for questions. We have one less panel member with us today, so that we're going to probably end this a little bit earlier than we did before. So what we're going to talk about today is I'm going to do a little bit of an overview of payment policy, hopefully not to put you to sleep, just to put this into context about where we're moving from fee-for-service into some other model. And I will say that the reason that we're talking about this is the reason that I've gotten into it. Never did I think I would be working at the Centers for Medicare and Medicaid Services, but truly believe that changing payment policy will change care delivery. And that is the reason. And hopefully we're going to move towards having a payment policy that may better support us creating a culture of health, as we've heard just a little bit ago. I'm going to do a general overview, and it won't just be about fee-for-service towards bundles. We're using bundles, but there's a whole host of ways that we're moving fee-for-service. It could be global payments, value-based payments, alternative payment models, full or partial risk, just accountable care, so basically paying based on some kind of outcome as opposed to just paying fee-for-service. And then you'll hear from the true experts, and each of the 2 folks here on the panel will describe their institution, the work that they're doing, and how the change from fee-for-service towards another type of payment has enabled them to provide care differently. And hopefully in their stories, you will hear yourself in the opportunities and the descriptions that they have there, either in how they are doing it or possibly many of you are doing it at your own institutions. You'll hear about roles for clinicians, for academicians, for researchers, for administrators. How is it that we can all pull together and try to create some models like you're going to be hearing? And then I've got a couple questions. They're going to be brief. They're going to tease you a little bit and want you to know more about it. Then I'll ask them some questions. We'll hear kind of collectively what they're doing. You can compare and contrast and again see how this fits with your own experience doing this. And then we're going to open it up to you. And we'll have both the comments at the microphone as well as the questions. And look forward to hearing either questions for how they've done it or maybe even some examples of how you're doing it at your home institution. So first, moving away from fee-for-service. We've been hearing the evils of fee-for-service for years, decades, the problems that quantity versus quality, volume versus value is creating. But how are we doing that? That's an much easier thing to say, much more difficult to be able to actually do this. one of the things that when we started, I've been at the Innovation Center, CMS Innovation Center now for 4.5 years, and most recently I'm the Chief Population Health Officer at Medicaid. But way back when we started talking about, at the Innovation Center, funding new models of care delivery, new models of payment reform that will improve care and decrease cost, I oftentimes had in either a hard copy or forwarded later a copy of Dorothy Bruton's study done back in the mid-'80s, where she did a randomized control trial, got it into the New England Journal of Medicine to show how we could get babies out of the NICU sooner. If we provided intensive nursing services, and I'm afraid to even say too much more because I know many of the experts that participated in that and subsequent work are here. But I did that to show, for a couple reasons, to the folks that we were working with. And remember, there's not a lot of clinicians that are working at CMS. But to show that it was because of the incentives being perverse. We had the wrong incentives. We have a healthcare system that it's doing exactly what it was designed to do when you're paying for more services. And when we have an intervention like the home visiting, the transition, and all the work that's being done now, what that ultimately does is decrease, for example, NICU visits. Hospitals weren't necessarily wanting to decrease NICU visits. In children's hospitals, the NICU oftentimes was the cost center that paid for the uncompensated care that was delivered in the emergency room. So the other reason I used to bring it up was because to remind folks that what we were doing at the Innovation Center may not have been so innovative. What was innovative is that we were now paying for it differently. And a lot of these ideas have been around for a long time. A lot of these ideas have had their homes in nursing care back to the settlement houses and the way that Florence Nightingale has delivered care for a long time. So we know that, we acknowledge that, and I was using clearly nursing examples to be able to show other folks at CMS kind of the long history that we've had in this and why we need to make these changes. How are we going to make this happen, though? I've been thinking about kind of the groups that are doing payment reform in 3 different buckets. First, you have the bucket of the folks that want to make this change. They want to move to a more value-based payment system. And they know how. They have a vision. And they've basically said to us, get out of our way. There are perhaps policies, things in place that have made it difficult for them to make these changes. For those, what can we do? The middle group is folks that say, I'd be happy to do that. Don't have the bandwidth, don't know how to make it happen, but we need some help getting there. And then the third group is that group that's doing just fine in fee-for-service, thank you very much. They don't necessarily have that incentive. And so what can we do there? There we have to move a little bit more towards mandates. So really quickly to tell you kind of what we're doing in each of these 3 areas that then hopefully is enabling, and what you're going to hear here, obviously, are the innovators, those in the first bucket that have been moving along. And I'm sure many of you are participating at your home institutions in similar kinds of activities. So at the Innovation Center, we've been funding these new models of care delivery, and it's been fascinating to be able to work with such leaders in the field who have thought about why payment has gotten in the way, why the policies that we have gotten in the way. And as I was a clinician for many years in Philadelphia, I could think back to very specific changes in policy, payment policy, that affected how care was then delivered. Some of the things that we've done also have some nursing roots. As Risa mentioned before, one of the great examples is delivering primary care in someone's home. A bunch of home care docs and nurse practitioners said, we know how to do this. We want to go to the frail elders. We want to provide primary care to them in their home. It'll keep them out of nursing homes, but there's a payment policy that says you can only get reimbursed if you provide these services in a certain place and it wasn't home. So we created what's now called Independence at Home. It's doing quite well, and we're actually moving forward doing that. Another one that I had spent a lot of time doing was, and I think a lot of folks here this will resonate, there's a rule called the 3-day rule, that you have to be hospitalized for 3 days before you can go into a skilled nursing facility. I'm a pediatric provider by training, so I didn't really understand much about it. But being able to work really closely with our Centers for Medicare, I was able to work across the center and create a waiver for this, create a waiver so that they could either be directly admitted, patients could be directly admitted to a skilled nursing facility or get out sooner than 3 days for our Pioneer ACOs. We were then able to test that for a while, and that's now moving into some of the payment policies for our Medicare shared savings ACOs. So get out of the way. So in the first case is how can we get out of the way? Where are there policies that are actually standing in the way of allowing this success? And the other important thing that we're doing at the Innovation Center is really rigorous evaluations of these. So we don't want to make a major change unless we have seen and been able to demonstrate that there was some kind of either, not necessarily even a cost savings, no increase in cost, but then an increase in quality. So that's the first group. The second group now, they want to do it. Happy to, interested, putting some bandwidth behind it, but they just don't know how or don't have enough infrastructure to make that happen. And there's a couple of things that we're doing there. The first was kind of getting our own house in order. Some of you may know that back in January, Secretary Burwell created some goals for Medicare fee-for-service. And we created goals for ourselves to move away from Medicare fee-for-service towards either value-based purchasing or alternative payment models. And we're using them differently, which we won't get into here because we want you to get to the really exciting folks. But we've set goals for ourselves of where we want to be in 2016, where we want to be in 2018 in terms of each of these different payment models. But then, because we knew that it couldn't just be Medicare, any clinician knows if you have a different payment model for each of the different patients that you're seeing, it's really hard to create that change we're looking for. So we created what we call now the Healthcare Payment, Learning and Action Network. We have over 6,000 people that have signed on to it, and it's available if any of you want to sign on, see the work that we're doing. It is a public-private. We've got many of the big private payers that are involved too, and we're going to be working through a series of issues. The first is defining what do we mean by alternative payment model? What are folks thinking of? And then some of those really boring, what are the benchmarking, who's attributed, what's my population? But if we can have payers align themselves to do that in a similar way. No mandates, we've invited folks to come join us, and we're moving forward with that. The last thing that we're doing now that is not something that we've done, and luckily and excitingly, it's a bipartisan issue. So many of you may have heard that back in April, there was a law passed in Congress that actually eliminated what we used to call the sustainable growth rate. The way that we used to, it was a formula that was put in place that said, oh, if there's going to be too much spending, this will go in and this will solve the problem, this formula, which didn't work. Any of you who worked with the House or Congress knows that this is something we fight year after year. This year, in a strong bipartisan effort, there was a law passed with yet another acronym. It's called MACRA, the Medicare Access and Chip Reauthorization Act. And it creates a new way of incentivizing providers to change their payment. This now is something that is more mandatory. You now have a different way of getting some incentivized payments, and for those who are happy in their fee-for-service world, there will be a new system in place that has you compare your practice to 2 years before and compare to national benchmarks, and your payments will either go up or down based on how you're doing. Or you can be exempt from this if you can demonstrate that you have a certain percentage of your practice in one of these new alternative payment models. This is the next group, folks that need a little bit more urging. At the Innovation Center, we've created now some mandatory bundles. First, the bundled payments that we had was folks, if they wanted to participate, they could. There's now some mandatory bundles for certain regions of the country where there was huge variation in getting replacement knees and hips. Where we saw that big variation, that means room for improvement. There's now some mandatory bundles there. So this is kind of, we've talked about this for a long time. It feels like we've got things in place now that we're moving forward and trying to make these differences. What does it matter? Well, I think everyone in this room knows if we could change the care delivery, what does it mean for nursing opportunities? Huge. We've been doing these kinds of things for years and years. We understand many of the things we just heard Risa talk about, going into the community, why that matters, how we bring that in together with the care delivery, looking at the traditional clinical care and how that could be expanded if we can pay for it differently. It also means improved patient care, improved communities, et cetera. So without further ado, that's where we are kind of in the context, and I'll turn it over to my colleagues. They'll be able to do an overview of their program, and then we'll open it up for some questions. Thank you.
Thank you. Good afternoon. My name is Chris Stanley. I'm going to share just a little bit about our organization, a little bit about where we are in the journey, and then I'll quickly pass it back over to Lauran, to my colleague as well. First, I want to thank you all for allowing me to be here today and share a little bit of Catholic Health Initiative's story. As hopefully an innovator, we've made a lot of positive moves, also made a lot of stumbles. I think some of those things will come out in a bit of our question and answer as we're going through our dialogue here. First, I want to also say Happy Care Management Week for those that are care managers. And also want to especially thank my colleague for this work, my dyad partner as well, Kathy Sanford, who's CHI's Chief Nursing Officer, who is allowing me to get up here and share a little bit of our particular story, because I live and breathe this every day. I think a little bit of an overview for CHI, if you're not familiar with this. We're one of the largest faith-based health systems in the United States. Frequently, we're not particularly known because we tend to brand ourselves locally. We actually have about 105 hospitals in around 18 states across the U.S., employ almost 100,000 employees as well. And what that gives us the opportunity to do is to be a very complex, very fee-for-service driven, a very difficult organization to sort of get your hands around, but it gives me the opportunity as the lead really for our population health activities. I started about 3 years ago in this new role at CHI to be very innovative, to be very focused on our communities that we serve, tying back to our mission, tying back to quality, health status, also patient experience, and frankly, provider experience as well, and total cost of care, so triple aim elements. And we do it really through a few different programs or areas. So within our footprint in the 18 states, we have 10 different accountable care organizations, each of which is very, very different, from Tacoma, Washington, to all of Kentucky and Nebraska and Iowa. They all are doing things very differently, all still structured in the ACO, especially around 10 different Medicare shared savings programs. We have multiple different bundled payment for care improvement, or BPCI programs, starting off in joint replacements. Now we're into heart failure, spine surgery, and other procedures as well. And then we, from a last piece, which we may or may not get into a lot during our discussion here today, we are not using in a negative way, but able to work with our own employees as a self-funded insurance group to be able to try, test, see what works, what doesn't, from a very patient-centered, but frankly also a consumer-centered type of a way to see what is working in population health. So we're learning with our own employees, demonstrating value so we can actually have proof results, and see how we're doing from a business and a financial side, from a community mission viewpoint, from a health status viewpoint, but then what are especially the policies and the processes that we want to put in place. The last thing I would mention that is, I want to set this up related to CHI, is we are approaching our population health work, which can be incredibly complex and incredibly challenging, and most of you know that population health is such a buzzword nowadays. Feels like next week somebody's going to name their newborn baby population health. It's such a popular thing. But the way that we structure it within CHI is really in three key pillars, or three key strategic pillars. One is around the network. Who is it that provides the care? And not just health care or health care services, but total health as defined by the individual, not just a patient, but the consumer. So that includes physicians, advanced practice clinicians, our hospitals, pharmacy, therapists, but also community collaboration along the entire journey of care. So that means that while we don't necessarily own the entire journey of care, we partner with subacute nursing facilities, long-term care facilities, churches, schools, and others to really understand what the needs are. So that first pillar is around the network. Who is it that's helping support that individual? The second piece then is the broad definition of care management, essentially the glue that holds all of the care together between each one of those nodes, or those particular places of healthcare and health-based and prevention type of services. And that includes a strong component of nursing, social work, pharmacy, nutrition, exercise physiology, spiritual health, all that goes along with that. And then the last piece, which is really critically important, is around data and information. You only can really provide good population health if you understand your population, if you understand how care is being provided, where gaps in care are at an operational level and at a 30,000-foot level. So those three pillars around information management and data, care management, and network are some of the items that I'm going to especially talk about as well during some of our questions. So thanks again very much for allowing me to be here.
Good afternoon. It's an honor to be here with you today. Ellen's given you a beautiful introduction to the national level of policy and innovation around payment. Chris has given you a large system level about what's moving related to being prepared for that. I'll talk to you a little bit about what it's like on a day-to-day basis to lead an innovation that intervenes with populations and how some of the funding shifts have actually created a beautiful opportunity for the voice of nursing and the voice of the interprofessional team to come forward to truly change systems. 4 years ago, I started working with complex populations. I was asked to get involved with one case. I was the director of the Pain and Palliative Care Service, and this one case was full of drama, complexity, fighting, arguing, multiple systems, lots of chaos. Had nothing to do with pain and palliative care. But they said, whatever that thing you do with hard patients, will you get involved in this case? I said, okay, I will try. The first thing I did was a 10-year analysis of the medical record because I knew if I was going to walk into the room with multiple neurosurgeons, multiple hospital systems, multiple people, I had to be really clear about what was happening in this case. What I found is the patient actually was being treated for a condition she did not have. There was tremendous fragmentation in the medical record. She had misrepresented her medical history out of mental illness. But the chaos and fragmentation in her case was coming from that loss of patient story. So the intervention involved pulling everyone together into an interprofessional team to develop a shared plan of care, transitioning that patient safely to the right care, including integrated behavioral health, including addressing social determinants of health, supporting the providers and helping them to link back together and stop fighting and see the greater story. That one case saved the hospital $1.6 million in unreimbursed care. So 4 years ago, in fee-for-service world, that was very popular. So they said, whatever you did, please start doing more of it, but you have no staff and no budget. I said, okay. Let me see what I can do about that. So I ended up first studying who were our biggest customers. I wasn't funded by a grant. I wasn't funded by a payer. So I wanted to know who is our high-cost, high-needs patients, what are their patterns, what are their subpopulations, and then what's the root cause going on, and then what would be the most helpful thing I could do to address the needs of these patients. What I found was a large population of people that were primarily under 60 years old, high degree of mental illness, trauma, social determinants of health, and people who had multiple care managers. They just weren't linked together. So I ended up creating a model of intervention that brings forward the person-centered story, links providers into a shared conference across systems, whether they're competitors or not, into a shared plan of care, embeds that plan in the medical record, and then follows the patient for life. In addition, from the Complex Care Center, we develop data analysis and information across the clinically integrated network to help people understand who the patients are, what the person-centered story is, and what we might want to work on. What are the process improvements that will help change the root cause? So, for example, bringing forward evidence-based physician order sets for treating gastroparesis, or fixing the transportation system in our community for the people who can't get to dialysis. And that's why they're coming over and over, because they can't afford transportation when we don't have the right links. And then population interventions linking with the community. So I lead a complex care center now that follows more than 1,200 patients and adds 5 to 10 new patients a week. I'm also part of Trinity Health, which is one of the largest Catholic healthcare systems and is led by Rick Gilfillan. So if you're familiar with him, he's a former director of CMMI. So we went from complete fee-for-service world to complete everything ACO, wonderful bundled payment. It's the most innovative time I've ever been in healthcare. So I also lead the bundled payment project. We are currently adding 10 patients a day in the bundle payment project with all the ones that we're signed up for. So I can answer for you questions about what is it like to do that in practice. One of the key, most exciting principles in both arenas is that these shifts in payment are resulting in walls coming down for us to talk to each other across systems. It's also bringing the role of nursing forward as a care coordinator and integrator across systems as key. So it's a very exciting time, and I'm happy to share more of that work with you and appreciate being with you today.
Thanks to both of you. One of the things that was clear in just that brief overview is that leadership matters. And so I think one of the things is what went into that process of making that change. Folks are doing quite well in fee-for-service, and that's an issue, but we need folks to make the change. Leadership could be a mission of the organization. It could be an individual who comes and has a vision to go. But maybe talk a little bit about, if you're aware of, what was that decision like? Why did they make that decision to move in that direction, and then perhaps some of the opportunities that, or how what you're doing can be different because that change has been made.
So I'll tell you one story that really illustrates that. In the beginning, so after that case where it saved $1.6 million and it was really exciting and everyone's like, yeah, do that some more. I worked with about 250 patients the first year, and at the end of the year I was reporting outcomes, and I was ecstatic because the reduction in visits was very high, really decreased ED, decreased inpatient, decreased costs of care, really improved quality outcomes. And I was meeting with the executive team to report that out, and there was kind of a cold quiet in the room. So you have to think this is fee-for-service world. And the CFO, after the end of the presentation, looked at me and said, we're going to actually hold you personally accountable for a $2.5 million loss in our bottom line. And it never occurred to me that doing the right thing for patients would result in that. But it was the most helpful thing anyone ever told me in the journey of creating this, because he was right. In fee-for-service world, I was very dangerous. I was decreasing our most frequent customers, and that can represent a lot of income. So what he taught me in that one moment is it was also my responsibility to think about the business case, and now I can explain the business case to you 7 ways from Sunday around why we should do this better. But intentionally from the beginning then, I proactively intervened with uninsured and Medicaid patients to balance out the effect. And I intervene with patients whether they engage or not, because I'm primarily looking at changing this system. So if you are in fee-for-service world, you have to get very good at articulating the business case about why. If you're lucky and you're in a world like we are now with Rick Gilfillan, where it's all about risk, then everything about care coordination and improved linkages is the complete focus, and you don't have to build the business case anymore. But getting very articulate about the bridges to help people see the greater context of improving people's lives affects their families and the community, and then finding the other costs in the system that are being saved and linking that with the CFO is critical for business success in this.
So I would tie into that, and while we have outstanding national and local market leadership within CHI, we don't necessarily have a Rick Gilfillan who is so 100% committed to it. What is great, though, for our organization is several years ago, the leaders of our organization did say, not only this is really where our mission is, we really need to be focused on our community's health, and this is the right thing to do, but also made bold statements, both internally and externally, to say, here is the direction that we're going. And they made very clear goals, set out very clear goals over multiple years as a destination type of goal, and for the most part, have been able to hold most of our senior leaders to that from an accountability viewpoint. I will absolutely say, though, it's very tough because we are still almost exclusively paid fee-for-service, and it's really tough, whether you're talking about readmission rates, whether you're talking about premature babies being born and keeping them from being born prematurely and out of the NICU. In some ways, we are still revenue centers in our facilities. We're not cost centers, and we have to absolutely change that view. I would say that our senior leaders have been good with setting out the vision, allowing individuals like myself and most of our other markets with my counterparts there to drive the vision. But I can't emphasize enough as well your comments, Lauran. You have to have the clinical case. You have to marry what's the right thing to do for the patient with the business case at the same time. So as one slight example, focused just on readmissions, and while I won't share too much proprietary confidential information, we a couple of fiscal years ago, we had a very concerted effort across the entire enterprise to drive down readmission rates. We chose, for example, the LACE predictive modeling tool, Project Red, as two very hospital-focused tools in order to help us out with that. We were able to decrease our all-payer, any-cause readmission back to our own facilities enterprise-wide by about 5% within a year, which was a pretty sizable decrease for the size of organization that we are. The next year, however, it actually went almost back to where it was before because the payment model and the incentives were really not aligned for driving that down. Every readmission we prevented was actually a revenue generator. Under our bundled payment program, and here again I'll focus especially for our first 4 programs for joint replacements, where we measure actually in that case a 90-day readmission rate because of being in that 90-day model too. We've actually decreased for our joint replacements by 50% our readmission rate. So we've been 10 times as successful as what we were able to just in the overall piece because the incentives align. People understand and they get it, and it's been sustainable from the very first month that we entered the program, continuing past that time. So when the incentives align, you then are able to pair the leadership with the process, with the incentives, and everything aligns very well, and that's why it's able to get really that culture of change.
So you've talked about the incentives, and when we talk about a value-based payment, it means you'll get paid if we see value. And that's not always so easy. What is it that we're looking for? How do we say, yes, this is the right direction, and when we see improvement here, then the payment goes one way versus improvement somewhere else? So what are the value metrics that you're looking at? How does that enter into it? And one of the questions that has come up that kind of ties into this is, what does that mean for academicians and researchers? As we've got a whole room of them here that are looking for how to make their research relevant and possibly useful. And the one reason I think it's really important, too, is because we know that some of the funding for research is dying down, but I would imagine that both of your institutions spend a lot of money on folks like Lewin and external groups to help figure out these utilization patterns and maybe some of this value, and it would be interesting if some of those dollars could actually be focused towards researchers who are an academician to possibly help make some of these links.
Yeah, so I'll probably answer that in a couple of ways. One is from an operational viewpoint. We track at each one of our markets and system-wide certain key performance indicators. Frankly, we do just a handful, not because we couldn't come up with 50 or 100 or 200 different metrics, but because if we're talking about process change, monitoring, sustainability, we are not wanting to take the boil the ocean type of an approach. We want to be very, very focused. So we tend to put our construct within the triple aim, putting first having to do with health status for some of the elements that at least we can get to. That primarily we then boil down into quality metrics. We tend to use diabetes many times as a proxy for other coordination of care. So we look at hemoglobin A1C rates, other screening, basically HEDIS type of rates as well. You're looking at it generally as a composite score, diabetes, but we do it for certain other programs as well. So we have a quality or a health status component. We look at utilization and total cost of care as a very critical component as well in our managed populations. And we look at things like readmission rates, ER visits per 1,000 in a population, bed days per 1,000, primary care and specialist use per thousand, high-tech radiology per thousand, sort of traditional utilization type metrics in a population health world. Similarly, we also look at what's the patient experience, the consumer experience, and we want to make sure that we're tracking that along well. I mentioned a bit ago for our bundled payment with reducing our readmission rate. At the same time in that program, our patient satisfaction went up by 9%. So it's really, really important that we are not just focused only on the financials, just only on the business side, but is this a service that consumers are actually receiving better care, that they're receiving better experience? So those are our operational level metrics that we report out then on a very frequent basis. There are other metrics certainly that can be included and a lot of other evaluations too. We actually have several academic centers in our family. So we go from, hospital side, from critical access hospitals that may have an average daily census of 2 to an academic center that is always going to be relevant from a delivery of care side because of the very specialty and subspecialty care that they provide. And frankly, they'll probably always be paid or reimbursed in a fee-for-service way because of the variable risk, financial risk associated with it. But they are actually not only re-engineering how we train clinicians and other staff, team-based type of care. So how do we develop the health team and health care team of the future, but also from the analytics and the study, and really where does all this fit in, both with our mission as well as really community service. And yes, we do spend a lot of money for consulting groups. We want to spend that as much internally as possible. We actually have a grant, a foundation even internally, so that we are doing initiatives in multiple markets, Kentucky and multiple other places, looking at high-risk individuals, studying to see what works, what doesn't work, trying to share that as much as possible across both the community as well as nationwide, because we think that's part of our fundamental mission as well.
One point just to reiterate on that, I think it's the importance of balancing metrics. So we don't want to recreate what happened with HMOs where there was all about care stinting and the fear that everybody had. So as we're moving forward and we talk about the decreased total cost of care, we've got to make sure that those balancing metrics are there. If we're saving this, how do we demonstrate that we haven't withheld care that needed to occur?
Critically important. Again, I've seen a lot of examples where you're too isolated, too focused, and you miss something. Intended or unintended consequence, so you absolutely have to have a balanced scorecard in order to look at that.
Folks play to the test, right?
They do.
So you covered that really well, Chris. A couple of other things that we look at, one is provider satisfaction and perception about, is this intervention, what we're doing, saving them time? Is it improving the quality of their care and their understanding of the patient? And then embedded in our analysis, essentially the consult is looking at things like evidence-based scales for depression, anxiety, which is a very big driver of complexity, looking at ACEs scores, the trauma, but we're also looking at adult experience of trauma because I see that as very highly correlated with complexity. We don't have a big investment in data analysis and research support. So it's an ongoing piece of we're capturing this and trying to get it in place so that when we do get that support, we'll have it. The other thing that we're doing is capturing patient and person-centered stories and sharing those, because I think that's one of the fastest ways to translate changes in culture is when you hear from the person, what is it that made a difference for them? So we're doing that in person, bringing people into meetings, and then also through a web-based learning community, sharing those there as well.
That's a great idea. I'm sorry, can I add just one
Absolutely.
more thing? Maybe this is just a request for the audience.
Yeah.
One of the things we don't do very well, I don't think anyway in healthcare, is both capturing the patient's stories, but ultimately, what is it that's meaningful for the patient? Right. So we're great at measuring quality, the way that we define quality, and great to some degree about patient experience, the way that we define it. But many folks, and again, if we take joint replacements, they don't necessarily care that much about readmission rate, although they care about complications. They want to know, can they go play with their grandkids in 2 weeks, 4 weeks, 6 weeks afterwards? And I think we have not done a good job of doing good studies connecting the healthcare experience with what's really meaningful for the patient and for the consumer. And I think there's good measurement scores having to do with return to work, functionality, but it still, I would say, tends to be very healthcare delivery centric. It's not necessarily what's meaningful for patients. And I think making that connection, research would be really, really valuable. So I'd highly encourage folks in the audience to consider how do we connect that with the real consumer, with the real community-based experience.
You mean real patient-centered care?
That would be a great idea, wouldn't it?
Another one of those terms like population health that I always make people define when they throw that out there. What is it? Where does it really get to?
Yes, exactly.
And just following up on, Lauran, your point, care coordination is such a big thing. It's such a hard thing to measure, and we're looking at it at CMS and trying to figure out ways. Just quickly, any thoughts about what it is you're doing as opposed to kind of all the individual about the patient, but how do we measure that that care is coordinated, or even harder still, why team-based care matters?
So I think one piece that's critical is identifying the core principles about what you would want to see for anyone. When we first started the Bundle Project in Michigan, I was assigned responsibility for the Bundle Project without any staff. So there were no extra care coordination staff, so I had to figure out how do we pull together the interprofessional team and try to redesign what we're doing and improve outcomes at the same time without staff. So that was very helpful because we identified core principles for every person, cross-continuum of what you'd want to see happen. I think the more articulate we get about that, we'll be able to identify a bundle of things that we want to see happen for everyone, whether they're in a risk-based contract or not. Then there's an element of capturing, we're truly working in an interprofessional team to deliver. So the pharmacists are doing med review. They're getting meds to go set up so the person doesn't have a barrier from receiving medications on discharge. And we're looking at discipline to discipline, warm handoffs. So pharmacists from the hospital connecting with pharmacists at the SNF, the physician to physician, nurse to nurse. So it's no longer about one discipline. It's what does best practice look like for all of us so that we are surrounding that person with truly integrated care.
And certainly a research agenda there as well. Yeah. I'd like to ask for an extra hour because these questions are amazing, and it would be fascinating to hear them talk about this, but sadly, we don't have that much time. And I'm trying to weave these into some of the questions, too. One of the things that I think is exciting, especially on the heels of what Robert Wood Johnson Foundation is doing, is how we are going outside what we have thought of as the clinical community, that traditional clinical services, and how do we make inroads into bringing those bits of care into the care delivery model, and also what to do about the savings. We've often struggled that when someone does an intervention in one silo, like Meals on Wheels is a great thing that's funded outside, but it can decrease post-acute care cost. And so we've got an intervention in one silo and the savings in another silo. So given new payment models, how are you being able to reach in and bring some of these other ways of delivering care into the care delivery process?
So the first principle in the work that I do is to identify, in addition to that 10-year analysis, who is the cross-continuum team? Who is touching this person regardless of system? And then we all come together. That principle is also underneath the process and population interventions. So as we identify root cause principles, we're pulling together the community agencies across the community to work on solutions. So for example, our hospital is located in the center of all the psychiatric services, homeless services, very complex neighborhood. And there's a very big population of chronic inebriates who are the most high frequency, high cost, very challenging population, heartbreaking. So I went out on street rounds, I went to the camps, I met with the homeless agencies in the community, and what we talked about is what we really need to do is all sit together around a table and look at what do we have, what would it look like for us to provide health care in the neighborhood, combining the best of what we all do. The hospital doesn't need to learn how to start a homeless shelter. There's really great people who already do that. And the homeless shelter doesn't necessarily need to learn how to become a really great healthcare provider if we partner and share our resources. And then if we come together and build the business case around the data, so with the alcoholics in my community, there isn't housing first. And what that means is if you're drinking, you can't live anywhere. So you're going to live in the neighborhood in a camp, and then there's a population that are living in that fragmented way. And we have an opportunity with the data I have and the expertise that the neighborhood has to go to the entire community and say, which venture capitalist would like to come forward around this business case to help us build a housing first option? That's where we start to get really big changes, and so that collaboration, I think, is critical.
And I'd say we're at CHI probably approaching this from a couple different directions. One is, and I applaud Lauran, Trinity, and all of the work for the community-based type of work that's being done. And I think we have certainly some examples, mostly grant-funded within CHI for that as well. Part of the challenge with that is how do you take this great program that may be working really, really well for 50 patients, 100 patients, how do you scale that up, both across a market within our frame as well as across the U.S. or across a region? Because there's so much intense services, and healthcare and health services are so unique, community-based services are so unique, that it may not necessarily directly scale up, but what are the principles that we can take that we can apply to multiple different markets? So there's that aspect that we're trying to grow as over time. The other direction that we're taking is, as in our evolutionary phase, it's a big stretch for us to be thinking that there are actually even other healthcare providers that are part of a patient journey that may be our competitors. And so whether it's an emergency room visit, a subacute nursing facility that we don't own, our first step right now is how do we start working with those in essentially a co-opetition type of a viewpoint, that they're competitors, but we also need to work with them because we have commonly shared goals. And so how do we start to spread out for the care that the individual really needs in even just the traditional healthcare system? But we're also finding that ties back to the comments just a moment ago is more and more and more of the disconnects that you see on care coordination and health status are related to mental health, behavioral health, social milieu, where individuals live, in addition to faith and other types of issues. And so we're adding more and more social work type of capabilities into that entire continuum to make sure that we're surrounding the individual with the best total team-based or comprehensive care. So I'd say we're trying to approach it both from a traditional provider scope creep, if you will, but then also from more of a hotspot type of a view that we then are trying to grow as well.
I'm going to ask a follow-up question from one of the questions I got, and then we'll move to ask the questions from the microphones in the room. Lots of different folks, how do they all talk to each other, especially if we don't have electronic medical records that are speaking to each other? Any suggestions that you can offer about how you try to make that happen?
You've got that all figured out.
I do. Got it down. So part of what I do as well, I have a large innovation grant from Trinity, so I'm developing out replicable tools and processes for Trinity. So there's pieces that are rolling out nationally as well. The biggest talk and conversation is we need a shared care plan that everyone participates in and everyone uses, and we need this magical tool that no matter where you are, everyone will use it. And I've been part of initiatives to try to build that on the HIE and build that, and I've also received multiple tools like that from different consulting firms. And what I really think is what you first have to have is principles. Do you have a principle that you're not the only one in the care space? That this is really about the person and their story and figuring out who is in their cross-continuum team, and it's your job to coordinate. That's our job. That stops the reinvention of the wheel, and you don't necessarily need a magical tool that you're all documenting on. It's starting with the principles, and then we also identify who's the relationship for life. Who is the person that this person is most connected to? They should be the driver of the care intervention, whether it's the doctor or the office nurse or the home care agency that comes in every week. They should be the key driver of the communication and coordination. And then you can have a shared plan on paper or in the computer, but what really changes the intervention is those principles and coming together with that in mind.
Said really, really well. Really hard. I can't hardly add anything to that except with the principles. It's also what are the goals? How are we going to measure success? and that if you have commonly shared goals, the principles to get there, there's multiple different tools, there's multiple different ways to get there, but I've not, I love them in coloring books to see unicorns, but I've never, I think a commonly accepted communication tool is like a unicorn. Everybody talks about them, they love to see it, but it doesn't really exist. We do use some tools that are cross-functional and cross-system and continuation, but if you don't have the commonly shared goals and principles and the willingness, frankly, at times to pick up the phone, to go face-to-face, to meet the consumer or the patient where they are, then the best tool in the world, once that unicorn pops up, it's still not going to be the solution.
Well, I've been in so many meetings, too, where we say, okay, we got to design this, and what comes out of the meeting is all of these various agencies already have access to the information on the HIE. They're just not going there because they don't have the principle and the value to start out with. And not to fault them, they're busy. They're doing a good job. So if we don't start there, I don't think we need the computer.
So let's turn it over to, it is hard to see. I've heard that there's someone over here. Good.
Yes.
Someone can direct me. There we go. There are people out there.
Yes, hi, I'm Michael Dreher. I'm Dean of the School of Nursing at the College of New Rochelle. I live in one of the 7 disrupt states. That's delivery system, reform, incentive payments. Kind of complicated to recite that. But I went to the EMS website a few weeks ago, and I could not find where there were other states anticipating moving to disrupt, sort of commonly referred to as Medicaid managed care. And New York State's trying to reduce hospitalizations by 25% over 5 years in the Medicaid population. So my question is in 2 parts. First, can we expect, because the CMMS model for disrupt is very data-driven and excellent metrics on pediatric cases of asthma in the ER, are they decreasing, increasing, et cetera, et cetera. So can we expect more attention to disrupt? And the second question is, in New York State, one of the things we've not had an announcement on, and we've been hearing there's going to be a notification, and then the notification is squelched, but we don't really know what the educational level is going to be for the patient navigator, the case manager, the care manager, the community health worker. I mean, these are obviously federal funds, and I'm sure there either will be a state definition or will there be a federal definition of what educational level will these individuals occupy, because they're very important pieces of the disrupt network and the disrupt community. Many of the individuals in New York State are out there in the neighborhoods recruiting people who are qualified for Medicaid services but don't know it and have not been told about that. So the expansion, 1, and 2, the educational level of these variety of job definitions. And one last point, if we could stop trying to do things with no money and no staff, that's what we ought to be focused on in this country.
So I'm going to go backwards and talk first about the definition of the terms. And I think your point is well made. What is a care coordinator? What is a patient navigator? It's a different wherever you look. The one question is, I don't know whether you want the federal government defining what that is. Those things have tended to be at the state level or without a licensure, and we know what happens with scope of practices when people try to define what you can and cannot do. So it is kind of a slippery slope in trying to figure out how to traverse that. Again, research agendas, we'd love to hear more. What I was trying to do in some of our population health work at the Innovation Center is stop calling folks by the title. I have a care coordinator, and I have a care navigator, and I have this. What are the roles and functions? What are the roles and functions, and who is best served to do it? And quite frankly, if you've got a nurse doing this, or you can have a local community health worker doing it, we should have the local community health worker doing it, because that's the way to do it. But then we need to be able to identify when a nurse is doing it, how is it different? What are they bringing? It may on the surface look to be the same thing, but the nurse is interpreting it, analyzing it, and possibly doing something different with that. So I think that's something we probably we may or may not want policies, we may not want scopes of practice, but I think lots of great work to be done, and really would be really helpful as people move forward. Your second point about the disrupt is just to kind of, and I won't spend a lot of time, it's a Medicaid. We are helping states with their Medicaid programs. I used to say Medicaid was the silent M in CMS, And now I've said it feels more like it's the Ginger Roger because she did everything backwards and in heels. And with Medicaid, we do everything 56 times. And so every state we want to come with their kind of array of how they want to do care delivery. And New York's district is amazing, if folks want to talk to you about it, an amazing way of looking at delivery system reform, using the Medicaid authorities to do that. And what I will say is there is this one thing that you call district, but we're doing fabulous things across the country in many different states. And we're trying to pull together so we can be learning from it. But it really is the place to start being creative. There are lots of demonstration, all those waivers when I talked before about kind of us getting out of the way. We've had all sorts of really interesting things coming in that folks want to do with their state Medicaid programs that we are trying really hard to make those things happen, whether or not it's one of these 5 or 6 districts or whether or not it's another state that says, I want to look at housing issues. We can't pay for rent, but we have been able to support some housing opportunities in Louisiana, in New York, to be able to say these are support services that we can do to help people stay in their home. And again, moving towards that culture of health, helping to realize how states can do that, which is probably easier in state Medicaid programs than it would be in Medicare, but certainly opportunities that you guys could have in your home institutions. So we're over time, but we've got one person here, I think, that will, let's take that one.
It's a very short question. Virginia Saba, I'm concerned about the nurse you keep talking about. In nursing, they are in the room rate in hospitals. They haven't developed fee-for-service yet. So how do you see we can integrate with all the other professionals who have fee-for-service when we still remain in the room rate?
It's a great it's a great opportunity. I think the reason that we are moving away from fee-for-service so that we can hopefully not move into that problem again. But love to hear from the panelists.
So one point I would make, and that I continue to make in any rooms that I'm in, is there's a real opportunity with the shift to value-based payment to include pay for care coordination. So to include nursing pay. So with bundled payment, it's a wonderful model, and there's a bonus for the consulting firm facilitating it, the organization if they make savings. There's also an element for physicians' involvement, but there's not right now built-in payment for care coordination. So it's an opportunity, and it's an opportunity for us as nursing to continue to advocate for that, because you won't see success in value-based payments unless you have that integration and linkage cross systems. And of any discipline, nursing is most experienced and has the greatest depth with doing that in difficult situations. It doesn't mean that we don't need an interprofessional approach, but I think it's a real window for us to advocate on a policy level and an integration level for that payment.
And my one additional comment as well is what I love and what our organization is loving at CHI with the value-based type of programs is there's different alternative revenue streams, whether it's retrospective bonuses and true-ups, whether it's other types of mechanisms that allows the organization to do a lot of different things with that money rather than in a traditional fee-for-service. A service has to be done and then you get paid for it. And so it gives a lot more flexibility to do a lot of out-of-the-box type of thinking, bringing additional staff, training, team-based approach. So I would also encourage folks to think not in a more traditional fee-for-service style of way, as in, I want to be paid to do this one more thing, but rather, I want to have the dollars, and then I can figure out within my organization what makes sense and how to distribute that and fund the resources.
It's a very good point. Very fast. We used to be able to not build anything new unless there was a billable opportunity. So we couldn't grow a service unless there was a billable provider like an NP or a physician. Now the conversation is about what are the outcomes we're trying to deliver and what are the resources we need to put in place to get those outcomes. That's very, very exciting.
Which
for
I
all
think,
of us.
I think what Medicare wants us to do.
That's exactly right.
So if I could just, in summary, say that one of the reasons we had this panel today is because in talking to our edge runners, and Lauran is a perfect example of this, what we heard from them is that we cannot focus on what patients and families and communities need and want until we move away from volume-based fee-for-service payment to more of a global payment methodology. And so I'm pleased to say that the Academy has met with CMMI, with Patrick Conway, and said, we are here to help you accelerate change in this direction. We were invited to join the Healthcare Payment Learning Action Network, and Cheryl Sullivan, our CEO, represents us with that, and Eileen Sullivan-Marks, one of our board members, is also representing us with that. So we intend to keep our eye on this issue, and I hope that all of you will keep the conversation going in terms of we must move away from fee-for-service to more value-based payment so that we can focus on the patient's story and what patients, families, and communities need and want. Please help me in thanking this panel. Excellent.